So going forward, when you want to look at which technique is the gatekeeper, you have the echo tools, the SPECT and MRI, which have to be used in these kind of patients with severe LV dysfunction because of their high perioperative risk before you take them to the cath lab or intervene in terms of PCI or CABG. And all three techniques are good techniques, and all three techniques in the right hands, in the right institution, have a certain amount of validity. So we'll be just looking at some of them, and you will see that the echo techniques here have a very high degree of contractile reserve assessment and tissue volume loss, not to mention their easy availability, cost, bedside availability. The nuclear techniques again are very strong with metabolic, perfusion and membrane transport. And if you look at the MRI, it encompasses a lot of the echo features and nuclear features and seems to be a complete solution, although expensive and not freely available. So not only ejection fraction, which is important to classify these patients, we use echo for risk assessment, we use them for quantification of regurgitation, we use them for the assessment of diastolic function, the left atrial volume, especially in patients with HFpEF, and the RV, as we've seen, for looking at the right-sided disorders, and also for assessing patients who require a CRTT device. And when we follow these patients on echo, we will see the volume start dilating, the mitral regurgitation starts getting severe, and then they need to be intervened. So when you look at the dobutamine versus cardiac MRI, you will see that the dobutamine looks at the contractile reserve, dysfunctional segments, and the contractile reserve. However, in patients with pre-existing diseases, already thin walls, it can be a little difficult to demonstrate that slight improvement, and therefore, although the specificity is excellent, there is a little lower sensitivity. And sometimes with our obese patients, the acoustic window becomes an issue and the lower spatial resolution. When you look at the nuclear techniques, we have a very clear-cut plan as to how to look at their viability. And when we see the uptake more than 50%, we know they're clearly viable. Anything less than 30% is non-viable. And when you add nitroglycerin to these patients sublingually, they become as good as thallium or nearly as good as the PET FDG. But it is in the 31 to 50% patients, we really struggle to assess whether they're really viable or not. And what we do in our lab, because these are all gated techniques, we use technetium sestimate. We look for wall thickening in these patients. So if it is present, these are viable, and if not, they are non-viable. But this is definitely a gray area, and you will clearly see here when we're looking for subendocardial scars, the nuclear technique, which is below, is definitely inferior compared to what the MRI can show, the subendocardial scars. Here the nuclear technique is almost normal. So subendocardial scar assessment becomes a problem. And again, when you're looking for patients with multi-vessel issues, the nuclear technique, especially if you use adenosine in little sicker patients who can't walk, you can clearly demonstrate the ischemia. Here we are able to demonstrate the RCA ischemia here and the LAD ischemia here, all in one patient. So many times if you're judicious in using the technique, you can even cover up triple vessel disease, which sometimes can be an Achilles heel in this technique. Moving on to the PET scan, and we know that if the PET scan shows a mismatch defect, that means there is decreased perfusion, but there is presence of FDG or metabolism, and this mismatch defect is the patient who is going to benefit maximum from revascularization. So the PET and MR data is very, very similar, and the true positives, true negatives are again extremely similar. But if you look at the spatial resolution again, you will find, compared to the PET and the MRI, the tiny subendocardial scars here, which are actually very good for revascularization, are not even seen on the PET. CTA is the new customer on the block for looking at viability and heart failure. And number one, you get to see the coronaries, which is an important thing for our patients because we want to know if there's coronary disease or not. But we're also able to look at scar now by doing delayed imaging, as you can see here. You have to wait for 6 minutes after a routine CT, and you will be able to assess the scar, and the scar burden spatial resolution is almost as good as MRI. The only problem is you have to do 2 scans, and that adds to the radiation burden. In patients with CTOs, again, CT is very valuable because it not only tells you the lesion, but also tells you the distal vessel below that. And what we use is a CT rectus score, which tells us how easy or how difficult this CTO evaluation is going to be. And then if you add the viability to the CTO, then you really know how much benefit you're going to get. We are moving into hybrid imaging, and SPEC CT is becoming commonplace in most of the metros now, where we are able to look at the coronaries like in this patient, and also we inject technetium, and we are able to get both the ischemia in the right coronary, and we are also able to get the occluded vessel and the vessel distal to it. So hybrid imaging is coming in a big way. The big problem obviously is the lack of large amounts of data which echo and MR have, and radiation is a problem. But again, with higher end CT scan, the sub-millisievert or near sub-millisievert radiation is coming into the picture. Obviously, we have to give iodinated contrast, and that could be an issue with both patients with renal and cardiac impairment. So finally, this young person had an angio, and as you've seen, it was a normal angiogram. And this was what, this was what his MR looked like. Sorry. So, yeah. So a dilated, hard dilated LA, there's a moderate mitral regurgitation which is central, suggesting that this is more of a secondary mitral regurgitation. And if you look at the screen on the right, you will see that there is absolutely no scar. The myocardium is pristine black, and that's very, very important for prognosis. The other thing that we do before putting this patient on medication is doing the genetic testing, and we do that for all patients who have a family history of DCM, family history of sudden cardiac death, or somebody with a rare genetic disease, or somebody with a severe kind of phenotype which has a sporadic DCM. And we do that for the index patient and the children of the patient who are more than 10 years of old, or siblings. So we have a center in Hyderabad, CCMB, where we send our patients, and we get a certain amount of the genetic panel is sent, and then we get the sequences if they're important. And there are a couple of patients whom they're all negative, and of course they're just kept on medical management. So I will stop here and just tell you that the management again is based on both the lifestyle, which is important, and the Fab4 drugs, and looking also at the precipitating causes before you start treating them. I'll stop at this point. Thank you.